Please, the floor is yours, Mustafa.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Good evening, everyone. Welcome again to the educational webinar series organized by the Iraqi Stroke Network. All our webinars are endorsed by MENA Stroke Organization. This is our 16th educational webinar. Today, we have a distinguished expert in the field of stroke medicine. He will talk about a very important topic in acute stroke care. My name is Mustafa Al-Kaabi, a neurologist at Al-Imam Saada Teaching Hospital from Babel in Iraq. The Q&A section will be led by Dr. Ola Abdul-Rasul Al-Khazraji. Dr. Ola, you have the word now.
Good evening, everyone. My name is Dr. Ola Abdul-Rasul. I am a neurologist at Imam Al-Sadiq Teaching Hospital, Babel in Iraq. Tonight, I will lead the Q&A section at the very end of Dr. Gauhar Malik lecture. Please put your questions at the chat box and I will read them aloud to speaker. If one wants to speak, please press the raise hand button. Thank you. Now for you, Mustafa.
Thank you, Dr. Ola. For now, I'll leave the word to our panelist, Dr. Aktham Iraqi, a consultant in stroke medicine in UK. The word is yours now, Dr. Aktham.
Good evening for everybody. Thank you for the invitation and the attendance. I introduced today one of the best neurologists I met, Dr. Malik. He's a consultant neurologist and with a special interest in stroke since 2018. He based in a very busiest tertiary centers in South Mead Hospital in Bristol. He has been involved significantly in the development of stroke service by auditing and lead in quality improvements. He is also the lead in educational and medical schools and also MRCB courses. He has been developing service in regional in Wales and southeast, west and south of Wales, and also contributed in regional development protocol in Bristol. So I leave the platform to Dr. Malik. Thank you very much.
Thank you. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone. My name is Dr. Gauhar Malik. I will just get my slides up now. Can you see my slides?
Yes, I can see it.
Thank you. So it's a great pleasure to join you all today, and I'd like to begin by warmly thanking the Iraqi Stroke Network for inviting me to speak. I'm truly honored to be part of this important talk and series of talks that you've arranged over the last year or so to have the opportunity to engage with colleagues who are equally passionate about improving stroke care. So your commitment to advancing clinical practice and fostering collaboration in stroke medicine is very inspiring, coming from Iraq, and I'm grateful for the platform to contribute, help improve stroke services in Iraq. So today I'll be talking about the role of hyperacute stroke units, HASUs, in modern stroke care. So as I said, I work in the NHS in South Mead Hospital based in Bristol in the UK. So HASUs is a model that has transformed how we manage acute stroke care in many parts of the world. From streamlining emergency pathways to delivering specialist-led care from the moment the patient arrives at the front door. So HASUs have significantly improved patient outcomes, and I look forward to exploring their structure, their evidence base, and the lessons we've learned from their implementation, particularly here in Bristol. So thank you once again for the warm welcome and the chance to share in valuable exchange of knowledge. So I'm going to split my talk into two sections. So first, we'll talk about the burden of stroke, the evolution in stroke care, and the birth of HASUs, the importance and benefits of HASUs. I'll give clinical pathways in HASU pathway, the future of HASUs and the challenges we faced. And then the second path of the talk will be involving giving you an example of the Bristol HASU model and lessons we can show, and also lessons that hopefully you can take in Iraq. So every 2 seconds, someone in the world has a stroke. Every 6 seconds, someone dies of one. So what if we could change those odds just by changing where patients are treated in the first few golden hours? So we often talk about the golden hour in stroke. So that first hour after someone has a stroke can determine the outcome in terms of their morbidity, mortality, and full recovery. So just by changing how those patients are treated in that first golden hour really is of importance. So the chances of full or near full recovery from the stroke are much greater the earlier hyperacute treatment is given. I just want to share a picture. So when I was a medical student 20 years ago, it only seems like yesterday, but this was a picture of stroke care in the UK. It wasn't going anywhere. It was patients, there was no access to specialized stroke units, there was no thrombolysis, there was no thrombectomy. There was very little service that patients received, so they were normally managed on a general medical take. They were normally the last patients to be seen on the post-take ward round, and they were distributed all around the hospital, and there was no joined-up care at all, and patients suffered in terms of their outcomes, their morbidity and mortality. And if you fast forward to today, this is the picture we have of acute stroke. So time is brain. So we know that the acute treatment that we can offer has a significant impact on the outcome. So now patients, as soon as they develop symptoms, the paramedics phone straight from the field to the hospital as a pre-hospital triage, and the wheels of motion are started. The acute team are notified, and they are bypassing the general medicine and all the other areas of delay, and the stroke team are notified straight away. So in terms of treatments, we know evidence-based. We have the thrombolysis trials advancing up to 4.5 hours in 2012. Thrombectomy came along in 2017 after the initial Mr. McLean trials, and then we had the diffuse and Dawn trials, which extended the time window to 24 hours. We have aspirin, which we've long known about the evidence within the first 24 hours. And then fourthly, HASUs. So this provides level 1 evidence for improving stroke outcomes. So when we talk about TIA and stroke, so TIA, transient ischemic attack, symptoms lasting less than 24 hours. The majority of TIAs recover within 90 minutes. The stroke symptoms that are persisting beyond 24 hours. So this FAST campaign, this is a very successful public health government scheme that helped educate the nation, the public, in terms of stroke symptoms, and it really helped get patients into hospital quicker. So I'm sure you might have heard of this campaign. So it's the face, arm, speech test. So patients are asked to smile if there's a weakness down one side. Then they are asked to raise both arms up in the air, and if one side drops, and then the speech. So if the speech is slurred, the T means time to call 999. So this campaign really helped over the years to get patients to the hospital quicker. Because of this public education, there's no point in setting up a hyperacute unit if your patients aren't getting to the hospital in time. This public campaign has really helped to get patients in and be educated. So in terms of the burden of stroke, so we know stroke is the second leading cause of death globally. In the UK, we have 100,000 strokes per year. It's a major cause of adult disability. There's an enormous socio-economic impact. The NHS spends £3 billion annually on stroke care, and the broader costs are 26 billion. So time is brain. Every minute without treatment, 1.9 million neurons die. So it's the acute treatment that we've now got available that has made us make sure that we have development of the acute stroke pathway. So if we think of the evolution of stroke care, pre-2000, so if you remember that picture of that old car I gave you at the start of the talk, stroke care was generalized. Patients were spread all over the hospital under general medical wards. There was variable access at CT scans. There was no rush. There was no treatment. There's no thrombolysis, and there's no specialist care. In the 1990s, they started developing growing evidence for stroke units. For instance, the Scandinavian studies that showed reduced mortality and dependency. And then in the 2000s, there was the introduction of all the evidence-based acute treatment of thrombolysis, mechanical thrombectomy, and that required rapid imaging, coordination, and specialist input. So that really ramped up the need to join up services. So in the UK, we have NICE, which is the National Institute for Clinical Excellence, and the Royal College of Physicians, which pushed for standardization of all protocols and streamlining guidelines. And then you had the Stroke Unit Trialist Collaboration in 2001, which had evidence for dedicated stroke units, which reduced death and institutionalization. And then the first thrombolysis trials in '95, and followed up with evidence within the 3 hours of treatment, and then the more recent 2012 study, which pushed it up to 4.5 hours. So in terms of the birth of HASUs, what is actually a HASU? So in terms of HASU, it's a hyperacute stroke unit. It's a specialist part of a hospital ward designated for acute stroke patients. So it provides 24/7 stroke care in the first 72 hours. Decisions are made initially about imaging, thrombolysis, thrombectomy, and once the patients have the initial treatment, there is continuous monitoring of vitals, multidisciplinary care, and rehabilitation services. The goal is to provide within a dedicated time window and identification of stroke cause, etiology, early mobilization of patients, and secondary stroke prevention. So the stroke unit significantly reduces stroke mortality. So the key features of a HASU, so you've got the 24/7 access to CT, MRI, immediate stroke team input. So you've got the 7-day working of consultants and specialist teams around the clock, which cuts out the delays in getting a specialist opinion in terms to treatment, to thrombolysis, thrombectomy pathways. You have rapid assessment, so swallow tests. So within our hospitals, we have protocols nationally that all patients should have a swallow assessment within 4 hours of entering the hospital. We know that swallowing impairments of 40% of stroke patients have an impaired swallow, and that increases the risk of aspiration pneumonia, that increases length of time in hospital, increases morbidity and mortality. So we have rapid assessments as soon as they enter in terms of blood tests. We have continuous ECG monitoring through telemetry, which aids in detection of arrhythmias such as atrial fibrillation, blood pressure control, all in one unit. And then you have this high nurse to patient ratio, which I will discuss later on in terms of our specific model, Bristol, and why it's required in a HASU. And then you have also early access to the multidisciplinary teams to early rehab. So the pioneering models of these hyperacute stroke units in the world were carried out in London and then subsequently in Manchester, and that significantly showed reduced mortality and improved metrics. So in terms of the importance and benefits of HASU, so firstly, the clinical impact, so improved survival. So the study that was carried out in London, so I've referenced it there at the bottom of the slide, the London Stroke Model 2010 to 2012 by Morris et al. And the BMJ 2014, impact of centralizing acute services in English metropolitan areas. So this was the major study which showed a 25% fall in mortality, which is the HASUs provide access to faster treatment, and in terms of door-to-needle times, improved dramatically. You have access, so as I said, you cut out all the delays. You don't wait around in the emergency department, you don't wait until to be seen and scanned. You're straight off the ambulance, straight into the scanner, and to the specialist treatment, and that reduces door-to-needle time, providing better outcomes. So more patients are treated earlier, they're discharged home, and they have less long-term disability. So the organizational benefits, so you have standardized pathways throughout the system. It provides safer environment, so you can monitor all your stroke patients in one area. In terms of workforce, you have improved training and workforce specialization. That provides increased motivation to the staff who are working in a specialized area where everyone knows their job. You have the cost benefit as well. So I'm going to talk a bit about the centralization. So when you centralize services, you have better outcomes, and that means there's fewer complications and fewer admissions or readmissions, or water out, or you get it right first time. So just a small example, so if you have a 72-year-old man at home, his family recognized through the FAST test that he's having an acute stroke, he's called 999, he arrives straight from the paramedic or call straight to the hyperacute stroke unit. They are prepared, and the patient comes in within 40 minutes, is straight away following brain imaging, CT scan, thrombolized within 30 minutes, and regains full function. So in a general hospital setting, there would be subsequent delays at each of those levels, and that would have an impact, particularly the golden hour, and subsequently day, meaning you'll have lifelong disability. So this table just summarizes nicely the research studies on hyperacute stroke units. So this one, in London, the stroke model I mentioned, 30% reduction in mortality, improved thrombolysis, centralization, improved outcomes. So London has a population of, I think, 12 million people. So they had lots of small hospitals admitting stroke patients, and they introduced 8 HASUs, and every HASU was within 30 minutes drive for everyone in London. So that was providing access, reducing and centralizing services. So centralizing Then you have London versus the Manchester model. So Manchester had a partial model, which was less effective, whereas London was a full HASU model. And that showed that having a full HASU model reduced death. Then we have our SNAP audit, which is our national audit process. So every hospital in the UK has, with the stroke department, has to submit data every 3 months on various aspects of care, and consistently on the SNAP that those hospitals with HASUs had higher scores in quality compared to those hospitals without HASU. there's national evidence on these. Then you had the NIHR study, which showed better MDT functioning and decision-making, supporting HASU configuration. And then you had the more recent GIRFT report, which was getting it right first time. There was significant variation in the UK, and they have strongly emphasized for every stroke center developing a HASU model. So just to expand a bit, just to explain the modeling and particularly workforces, very important for successful HASU. So this is an example of our HASU in Bristol. We have a 12-bed hyperacute unit, and just on nursing, so the Royal College of Nursing and NHS guidelines typically recommend that there should be one registered nurse for every 3 to 4 patients. On night shifts should be one nurse for every 5 to 6 patients. So 2 nurses on duty at all times, and including support staff. You have healthcare assistants also included in the staffing. So you need 1 support worker for every 4 to 6 patients during the day. So this is one of the reasons why a hyperacute stroke unit is different to a general non-hyperacute stroke ward. Get staffing level of care. So in a 12-bedded hyperacute stroke unit, you'd need in the day, you need 4 nurses with 2 support nurse workers, and at night those numbers are halved. So the idea is to prevent an unsafe on-call rota. You don't breach national standards. You avoid staff burnout and attrition, and you avoid developing poor patient outcomes and performance. So investment in a stroke workforce is essential to deliver a safe and sustainable model that is successful in the long run. So this is just a clinical pathway of a working HASU. So you think of the pre-hospital phase. Patient is at home, the paramedics ring from the patient's home, from the field, direct to the hyperacute stroke team, and they bypass the emergency teams, they bypass the general medics, and then the stroke nurse and consultant registrar team are alerted, and they arrive and meet the patient on arrival, and the patient is straight from the ambulance straight to the scanner, which is on the same level as the stroke assessment unit. So that's something you've got to think about in terms of logistics. And then you have the NHS exam as the patient is brought back from the scanner, and then thrombolysis can be given as quickly as possible. Ideally within 60 minutes, but more if possible within 30 minutes, the patient into the hospital. And so multiple delays are removed. The patient is seen quickly, scanned quickly, and assessed quickly by a specialist. Then the monitoring of the nursing staff continues post-thrombolysis on the acute stroke unit, blood pressure, neuro observations, glucose, and monitoring for any deterioration of complications. And then you can have the multiple-disciplinary team, which is based on the stroke unit, and that takes place within 24 hours, and then rehabilitation begins 1 or 2 straight away. So technology is also being used now in terms of adding to the hyperacute strokes units with telestroke systems, where you have geographic difficulties, particularly I know in a few developing countries where the logistics and geography are remote, so telestroke systems are beneficial in making that initial assessment. And then we're also using AI in our hospitals, so all brain scans have an automatic AI tool that provides a readout of the brain scan. So that just again cuts down the time in waiting for an MRI or in terms of CT report. And again, you're just saving time and helping you making that decision. So in terms of the future of HASUs and the challenges, so there is, in the UK at least, there is geographic inequality. Not all areas have access to a hyperacute stroke unit. Once you have a hyperacute stroke unit, there is a challenge of significant increase in turnover of patients through a very specialized area. So you have to monitor the number of non-stroke patients in terms of the mimics. We know there is always a double amount of mimics that are admitted to actual stroke. So managing those and being vigilant on bed management, so having a bed manager employed to help liaise with the front door team and the team on the ward to make sure that the beds are continuously being monitored and patient flow is being maintained, because you don't want to avoid blockages. And workforce is very important. It's nurses with specialist knowledge. You need protected job plans, particularly at senior level. And then there's workforce shortages in terms of physicians, specialists, therapists, and nurses. And then the other challenges in terms of the ambulance network. So there may be some in terms of issues in bypassing the normal policies that the ambulance is employed. So it's working with whole pathway from the paramedics, GP, primary care, and the emergency. In terms of future directions, as we develop, we have 26, I think, thrombectomy centres in the UK. The more thrombectomy centres we develop would need dedicated hyperacute stroke units. There's enhanced pre-hospital triage, particularly mobile stroke units being employed to help pre-hospital. So that would again be an additional benefit in speeding up the time in terms of assessment. Time is brain. So any way we can improve diagnosis and imaging potentially. AI, I've already mentioned, we've already started using that in terms of diagnostics, again, cutting down the time. If there's a shortage of radiology specialists, can be really helpful in making decisions. And now the most recent thing that we've started here in the UK is one of the first in the world in terms of personalized stroke medicine, where we have this tool, AI tool called Samuel 2, which you're able to input your patient's details in terms of the patient in front of you, their specific history and exam findings, and the computer will automatically provide you with the best possible thrombolysis decision. So that's again another important improvement in terms of making that decision in that golden hour. So moving on to the second part of the talk, I thought the Hyperacute Stroke organisation that we've carried out here in Bristol, and just some points to take in terms of practically how we've done this. So reconfiguration means centralization of services. So just like the London model, they had multiple hospitals in London, then they cut it down to 8 hyperacute stroke units. Ours took a long time in planning, 7 years, so it's not something that's going to happen overnight. And it requires full buy-in from the ED, from primary care, through the paramedics. And in terms of our population, the Bristol area and the surrounding is about 1 million. And we had 3 acute hospitals admitting stroke patients. And then in 2023, we converted it to just 1 single admitting hyperacute stroke unit. So all suspected strokes came to this 1 hospital in Southmead, all suspected strokes within 24 hours. So anyone beyond 24 hours would go to their local hospital. They're all suspected within 24 hours, i.e. they were eligible for acute stroke treatment, thrombolysis, thrombectomy. They would come to this in Southmead. What we found is that patients on average will be seeing a stroke specialist nurse much quicker, within 13 minutes of their stroke, and a consultant within 90 minutes on average. And we've seen that the studies have shown that 15 lives are being saved more when 60 patients are more living independently. So just to give you a brief idea in terms of how complicated it can be in terms of when you're setting up the service, in terms of how the patients are accessing the single hyperacute stroke unit. So you've got a GP, primary care, who could ring straight to 999, or a patient at home could ring straight to 999 and they would attend straight to the stroke unit. But then you've got those patients where the diagnosis, particularly with mimics, you need advice and guidance before ringing. So you have one consultant dealing with those queries as to whether to admit. Then you have patients who the ambulance crew are unsure in terms of onset, so they need advice and input. And then we have our two other hospitals in the Bristol area, WGH and BRI. They also have patients who just attend through walk-in, and they would also need advice and input. So you have a separate consultant dealing with that, as well as using what we call telemedicine to offer advice before we admit to the hospital and advise transfer. So then you also have the TIA patients who are suspected of needing admission. And then you have our rehab hospitals where patients also deteriorate as well. So it can get quite complicated in terms of when you have set up the service with one admitting hospital, you can suddenly find yourself overwhelmed with a lot of access pathways, and you have to develop ways to overcome preventing yourselves getting overwhelmed. So what have we achieved during this period? So as I mentioned, we have a national audit in the UK. So every hospital in the UK has to be assessed. Every 3 months, we have to submit data from time the patient comes into hospital, how long it took to have a scan. And this is every hospital in the UK is judged nationally. And at the end, you get a score, ABC. So we achieved the highest score since we became a hyperacute stroke unit. And that is backed by the evidence that shows that HASUs outperform non-HASU hospitals in outcome care. You're centralizing all specialist service in one area. So we actually had used fewer stroke beds and fewer stroke beds in the total system. It's a new way of working, provides cross-organizational collaborative governance, more collaborative approach to workforce, because workforce planning, if you have lots of hospitals which are underfilled, short-staffed, when you put them all centralized in one area, you have all the staff working, and that provides more collaboration in terms of rotas. And you have ongoing service user involvement in terms of audits and improvement projects. So in terms of what this all means for Iraq, in terms of establishing hyperacute stroke units, I've shown you the evidence that hyperacute stroke units, just like thrombolysis, aspirin, and thrombectomy, has shown to improve the outcomes in terms of morbidity and mortality and quicker discharge from hospital. So stroke care facilities remain limited from my understanding and my visits. I've been to Iraq 5 times. Few hospitals are equipped to perform advanced procedures such as mechanical thrombectomy. Obviously the geography, understandably, with a lot of war and conflict in recent years, has caused a lot of problems in terms of this development, significant delays in receiving the necessary care that patients need in that golden hour, which then leads to outcomes. You really need investment to help develop. So in the UK, we have strong government backing to, once the evidence is there, the government gets behind the NHS and drives forward these investments, because once the evidence is there, you really need to help spread and roll out these services to benefit your patients. So establishing dedicated training programs and partnerships with international institutions. So I welcome these talks that you're very commendable in terms of trying to improve the situation in Iraq. You're being active and looking to make these. So focusing on infrastructure, professional training, telemedicine, all of the above can significantly improve quality and accessibility of stroke care in Iraq. And I think it's important to think about the journey rather than just the end result in terms of all the different aspects of the pathway. And inshallah, you will make improvement. Thank you. And any questions?
Thank you, Dr. Malik, for very interesting talks to highlight the importance of the HASU, specialized unit in stroke. You show us really the three most important pillars for initiation of HASU, including evidence, as you elaborate in Scandinavian trial and London, and also the body who support implementing all these requirements, and a dedication of the neurologist and the service in the area. I would like to say first, as I am here, Bristol example actually is I consider it as luxurious, as you see it. So when Dr. Malik mentioned about Bristol, I will tell you it is the most luxurious, well-equipped, well-funded place in UK. So what Dr. Malik elaborates, you might not find it in other parts of the England. So don't scare from the implemented all what Dr. Malik, but of course it is the ambition for any unit, any stroke unit actually as a center to be comprehensive as it is in Bristol. And hopefully we have a chance to get some of the Iraqi doctors to visit that center if we have the chance. But from that prospect, there is hospital still not step into implemented HASU unit. It is not really late because also that is requirement. But what is important in Iraq example is that to consider HASU to be specialized. And if you achieve the specialized, then you're going to develop the interest from the team, from the physiotherapist or the nurses when they're going to develop their interest toward that specialized unit. And therefore, what I emphasize on the importance of HASU as a step after the implemented or the service in Iraq after thrombolysis, as we see it is evolving in Iraq, to adopt the example of HASU as Dr. Malik elaborates on the evidence and how that makes difference in the outcome, reducing mortality and also disability. So thank you again, Dr. Malik, and I leave it to the panel to see if there is any questions. And yeah, thank you very much again.
Thank you, sir. And now we move on to the Q&A section with Dr. Ola.
Thank you, Dr. Gauhar, for this nice lecture. Now we will move to the question by the audience. The first question from Dr. Mustafa Shahini is about, can you explain why HASU, hyperacute stroke nurse-patient ratio, is lower than 1:1?
So in terms of the safety and in terms of, if you think nationally, in terms of how to, we often have shortages in terms of stroke nurse staff. So that is in terms of a slightly relaxed, in terms of how you would manage compared to an ICU setting. But in terms of hyperacute stroke unit, those are the figures that have shown to be a safe standard for rolling out such a program in not just the UK, but it can be rolled out elsewhere. So in terms of you have, I'm not sure what the service is in Iraq, but you have registered nurses, but you also have the support working nurses as well. So you would have between so you'd have 2 registered nurses plus an individual support. So overall, obviously, it's not the level that you see in ICU, but as HASU, you have acceptable levels of care that is recommended from the Royal College of Nursing.
Okay, the second question is also from Dr. Mustafa Shahini. Do you recommend this ratio if we have plenty of nurses?
So in terms of, particularly for when you're first setting up, I mean, I'm not sure if he's talking about if it's the capital or he works in where there is more staff, particularly if he's thinking Baghdad, maybe. There are, you'd have more staff available. In terms of the levels that we've seen from the Royal College of Nursing, that is the recommendation in terms of safe minimum. So obviously, if you can have more than that, that would be fine. But in terms of safe minimum, and as Dr. Aktham said, that in Bristol we have one of the highest levels of tertiary care, and that's the level that we've been managing in terms of our HASU. So you'd have 1 registered nurse with 4 patients, 3 to 4 patients, and a HCA managing 4 patients between a registered nurse and a healthcare assistant. And it also depends on the type of ward you have, because we have individual rooms, which is slightly different to if you have an open ward. So our model is based on that because we have individual rooms, and then we only have 2 bays. So you have 2 bays on our ward, so you have 4 patients in each bay, and you have 1 registered nurse looking after those 4 patients, and then you have a HCA for that. Then the rest of the ward is all individual rooms, and you have 4 individual rooms facing each other, and 1 registered nurse and a HCA in that ratio.
If I may add, well, my colleague is here because in Iraq, still the HASU unit hasn't been set in a way. So all patient thrombolyzed go to ICU. That is what the model they adopt. Of course, the HASU versus ICU being looked at as outcome and the benefit of these specialized units. And definitely the HASU's unit shows superiority on ICU. So ICU, particularly in advanced service where is only allocated where requirement, like if somebody have no GCS or any of the indication required ICU, and Dr. Malik well known, they have a very big ICU unit of 48 beds. So now they have enough bed in Bristol. But as a principle, HASU, the shifting to HASU is the specialized and as Dr. Malik elaborate or requirement. Of course, if there is no alternative service, I don't think that we exhaust the other service, but yes, it is an option in this stage, but that is what we try to do is to shift to specialized units to have more specific care to the stroke patient.
So I don't think you would need, ITU care for every stroke patient. So that's why, in terms of the ratio, that's what is required. So I didn't understand that all patients go to ICU in Iraq at the moment. Is that post all stroke patients, or is that thrombolysis only?
So my understanding here is because the thrombolysis patient, when the thrombolyzed, still there is no dedicated, the best organized, well-set unit is the ICU. So that is the adaptation, the transitional period I call it. But as we are trying to demonstrate, as you demonstrate nicely, what is the level of care, and that's what we try to shift. So the model in Iraq will be upgraded, or when we adapt on the principle or model being tried on, as you elaborate on the two trials, and on monitors by the Royal College and Synapse, and how the outcome improve in mortality and disability. I leave it to you, Ola.
Okay, thank you, Dr. Gauhar, for these comprehensive answers. Now we have no more further questions. The word is yours, Dr. Mustafa.
Thank you for waiting to the end of this meeting. We remind you to follow us on social media and to join our network if you haven't yet. We are open to hear from you to develop our work, and we are looking forward to meet you at the next meeting. Last and not least, we want to thank Normal Pharma for supporting this webinar. Have a good
Someone
night.
raising his hand, Dr. Mustafa, please.
Okay.
So please, sir, unmute yourself.
Yes. Thank you very much. May I ask you about, Dr. Malik, about who decided that this patient has stroke? Suppose a patient in Iraq, when he lost consciousness due to syncope or seizures or stroke or something like that, or maybe psychological issue, he will be brought by families in Iraq, by his relative, to the emergency department. And there in Bristol or the UK, who decided that this patient has strokes? And did you receive a patient classified as a stroke, then you find it is not a case of stroke? Thank you very much for your nice presentation.
Thank you for your question. So we have the pathways developed associated with the setup of the hyperacute stroke unit. And it clearly states that patients who present within 24 hours of acute neurological change, they will be brought for assessment to the emergency department and seen by they will be initially discussed via telephone. So the paramedic who goes to see the patient in the field, they will make their assessment and then give us a ring direct to the stroke hotline, and then we will discuss and then decide. So if the patient is within 24 hours, that's the pathway. But if the patient is beyond 24 hours, then they would present normally to the emergency department as they would, because they're out of the acute window for treatment. So this hyperacute stroke unit pathway is only for those patients who present within 24 hours of acute onset. But if they have symptoms and history beyond 24 hours, they would just present to their normal local hospital, local emergency department, and be worked up.
So you mean those paramedics are nurses?
So in terms of their separate specialty, so they are paramedics. They are higher level training than nurses, but they're not doctors. So within the 24 hours, they make the assessment. They will do the fast test. They will check for acute history, because in the UK there's perhaps greater in terms of public health knowledge of the population of acute stroke symptoms, and so there's a higher rate of patients who actually have stroke symptoms being called and being assessed correctly by the paramedics, whereas perhaps there's not that education in Iraq, so every patient may present late, or they may be not appropriate by paramedics, whereas in the UK there's more public health awareness of what a stroke is, and therefore the paramedics will see patients who are more appropriate for the stroke service, and they will be easier for them to make that assessment. And then, but they would always discuss it with us first from the field, to make us aware and get us ready to cut out any waste in time in assessing the patient. Also, we can advise them and say, actually, no, that sounds more like a seizure. That needs to go to medicine or whatnot. So Yeah, anyone presenting with acute neurological change within 24 hours of onset would see as a hyperacute unit following discussion with the paramedic.
So did you receive patients who are not stroke and how many? Like brain tumor, maybe? Yes.
Mimics, yeah, absolutely. So our data shows that we see double the number of mimics than actual strokes who present to the hyperacute stroke unit. So we have, in our model, patients are brought in. We have what we call a stroke assessment unit based in the emergency department, and from there we can diagnose. And then, if it's not felt to be a stroke, then we either discharge them straight away, or we can refer on in agreement with the medical team who would take them over. So they would avoid ending up on the hyperacute stroke unit. So our model in Bristol is we have a stroke assessment unit in the ED. We have our own beds there, and there we can start the treatment before the patient is shipped to the hyperacute stroke unit. So it does give us balance to avoid admitting who are not strokes. So we do see double the number of patients per day in terms of mimics than not. So we still have to manage those initially, but then we have agreements with medical teams in the hospital. They will take over the patients, so we can focus on. But we're trying to improve the pathway so that we can reduce the number of mimics. That's always a difficult thing.
Thank you.
Okay, another question.
Well, I'll just take the question of Dr. Mustafa and then Dr. Tamim comment about nurses.
Okay, the question is about the point behind, what is the point behind keeping the patient for 72 hours rather than 24 hours, for example?
So we have telemetry based within the hyperacute stroke unit. So that gives us continuous monitoring, and that helps in assessing patients, particularly for atrial fibrillation, which is available only in the hyperacute unit. Once a patient is stepped down, they don't have continuous telemetry, and that's aid in etiology of patients. But obviously, if patients are stable and there's a push for patients new patients being admitted, then those patients would be done a bit more quicker, maybe 48 hours rather than 72. But ideally, we keep them for workup, but also if they are unstable, we would keep them in the hyperacute unit, because we do have a high rate of thrombectomy in our center. Almost 20% of patients have thrombectomy, so those patients to be good.
Okay, we have a comment from Dr. Tamim Nasser. The word for you, Dr. Tamim.
Assalamu alaikum.
Wa alaikum salam.
About the diagnosis of stroke, who can diagnose a case of stroke in Iraq? I would like to say that the new Iraqi guideline, they mention the decision to give activities to any case of stroke is only limited to neurologists. But to diagnose a case of stroke and to put it in the pathway, any physician or even any paramedics, well-trained paramedics, he can activate the system that this is a possible case of stroke who may benefit from activities. And right now, the Ministry of Health is working on a training program specified for nurses called Stroke Nurse, in cooperation with Angels, which is a non-profit company from global company to facilitate the access for activities.
Yeah, so in terms of our model, you have to have thrombolize a specific number of patients. You have to have specific training and continuous working with stroke patients. If you only see 1 or 2 stroke patients a year, that would not be sufficient. Because stroke is a heterogeneous condition, it's not straightforward. There is a lot of complexity, particularly in terms of differentials. So we would recommend that, I would support that recommendation in terms of neurologists, or it could be any specialty, but those who are constantly working with stroke patients to build up that competency and skills. Because you're not giving, you're not giving sweets. This thrombolysis is a dangerous treatment, and you don't want to get it wrong. So you have to be sufficiently trained, and you're constantly working in that. So I mean, any specialty can do thrombolysis, but they have to be continuously working in that their skill. So I would think, yeah, neurologists, and I'm not sure if general medics can do stroke in Iraq, or acute physicians in the UK, or geriatricians in the UK can do stroke treatment and be part of the stroke workforce. And the second question was about the stroke nurse. So in the UK, we have stroke nurses. They are very important in terms of the team, in terms of the stroke workforce. So you have a stroke nurse who would handle all the calls from the paramedics and would discuss the first call. And then when the patient arrives, they would be helping in putting in terms of assessment, NIHS assessment. But the decision to thrombolize would then rest with the consultant or registrar. So a nurse on her own wouldn't be able to make that decision. She would need support from a registrar or a consultant.
Thank you.
Okay. Okay, thank you, Dr. Gauhar. No more questions and no more comments. And thank you for this comprehensive answers. The word is yours, Dr. Mustafa.
Thank you again for this informative lecture, and thank you for listening and staying to the end. Have a good night.
Thank you. Assalamu alaikum.
Malik.